Hello, everyone. My name is Demuriel King, and I'm with the Wound Care Education Institute. And I'd like to welcome you all to the webinar today titled Nutrition, Recipe for Success in Wound Healing. This program is made possible by a grant from Shield Healthcare. This particular event has been created to provide an opportunity for education related to clinical topics that affect the wound care market today. WCEI continues to have one goal in mind: to improve the management of wounds and ostomy for patients across the nation. We currently support over 20,000 alumni through certification courses in wound care, diabetic wound care, and ostomy, as well as nutrition. Before we jump into the webinar, I'd like to run through a few housekeeping items. For those of you who are interested in obtaining educational credit, you will receive an email from WCEI within 24 hours after the webinar with instructions on how to obtain your certificate as well as how to view the recording of this webinar. Please be sure to check your spam folder. If you have not yet downloaded the handout for today's presentation from your confirmation email, you may do so now by clicking on the attachment in the sidebar under Handouts. The actual CE presentation should last about 60 minutes. So if you have any questions, please feel free to submit them in the question box at any time. If time allows, we will answer your questions at the end of the webinar. As a reminder, to receive educational credit for this particular webinar, you must be logged in to view the full presentation and slides. No credits can be awarded for those who do audio only. The accrediting body for this program is on the screen now. You can check WCEI.net to type. The planners of this course have declared no relevant conflicts of interest that relate to this educational activity. On-course learning guarantees this program is free from bias. And now I'd like to introduce you to today's speaker, Dr. Nancy Collins. She's a wound care certified registered dietitian. She has over 25 years of clinical experience dealing with the interwoven issues of malnutrition, catabolism, and tissue regeneration. She's also a medical legal expert and founder of Nutrition411.com. She currently is the president of Lightbolt Health Incorporated, a medical education company based in Las Vegas. She's also on the Speakers Bureau, as well as a consultant for Abbott Nutrition. Welcome, Nancy.
Well, thank you so much. Okay, well, I'm very excited to be here this morning. I'm talking to you from my office here in Las Vegas, so welcome everybody. I hear we have a nice crowd today, so it's very encouraging. Happy holidays, everyone. I'm glad you took time to join me today here. So let's talk about what we're going to do today. We're going to talk, of course, of my favorite topic, which is nutrition and wound healing. And what I wanted to do today was, because we have a lot of nurses joining us today, what I wanted to do first was just review some of the characteristics of malnutrition. I think that things may have changed, and you might not be totally up to date on how we diagnose malnutrition today. But of course, if you're not looking for it, you're not going to find it. And it's very important in today's environment that you document malnutrition, especially if we're treating it and if your patients are not healing. So we'll talk a little bit about that. And then, of course, we'll jump into nutrition. So how this kind of a program today came together was one of my editors had asked me to put together an article on the most important thing for nutrition and wound healing. And I started trying to write this article about what would be the most important thing. And I realized that that was not going to work. Everything kind of works hand in hand, and you can't leave out one little component of nutrition. And so I kind of came up with this recipe idea that it's almost like when you're cooking a recipe, you can't just leave out one ingredient for your recipe. It probably won't come out very good. And it's the same thing here when we're trying to treat our patients with wounds about their nutrition. We can't really leave out one component. One's not really more important than the other, was my conclusion. We need it all. So what I want to go through today is what I feel those components are and what's going to happen if you don't have enough of those components. And then hopefully by the end of this talk, you'll have it, hopefully at least 2 new nutritional interventions that you can take back to your practice, back to your patients, some ideas. Of course, again, I know we have a mix here today. Some of the dietitians probably know some of these, what I call them my tricks in my little nutritional tool bag, but maybe some of the nurses do not. So hopefully I'll give you some new ideas that are be easy to implement. So, okay, let's go ahead and get started here. Where do we begin? Nutrition and wound healing is a big topic. I only have, 50 minutes today to talk to you about this. So where do we know where to begin? So where I've decided to begin today is with malnutrition, because according to the research, depending on which study you look at, somewhere in the neighborhood of half of our patients are malnourished. And when I'm reviewing charts, which I do quite a bit, unfortunately, most of the charts I review are involved in some sort of litigation or some sort of problem that has occurred. And I don't often see that people are documenting that the patient was malnourished. Yes, I see a lot of these patients with chronic wounds that haven't healed month after month after month, and sometimes it is related to their malnutrition, but that doesn't get documented very well. And of course, anytime one of our patients doesn't have enough calories, enough protein, all of these other nutrients and cofactors that are needed for tissue regeneration, they can be malnourished. And that really does need to get into the charts. One of the points that I want to make to you is that it's not a black or white thing. Your patient isn't nourished one day and malnourished the next. This is something that happens over time. And again, when I'm looking back, when you review charts retrospectively, you get a whole different view. And when I look back over these charts, I can see that the malnutrition was building steam, and it was the person was heading towards a problem, and no wonder their wound wasn't healing. They were losing weight. They were hardly eating. I can see that the problem was starting to build up, but there's no mention really of that in the chart. So you have to remember that these nutritional problems don't occur overnight. They happen along a continuum over time, and you have to keep your eyes open for it. So what's happening here is that maybe their requirements, they need more than they normally would need, or they're not absorbing what they're consuming. Some of the wound healing impairs the way we utilize some of these nutrients. So we'll talk about that in a minute. But you have to be looking for this. And until 2012, there really was no consensus. What I called malnutrition may not be what my colleague called malnutrition. It was really just, everyone for themselves. But now, because of electronic health records and the future of interoperability, where health records should be able to talk to each other no matter where you're located, it's important that we all use the same terminology. How could records talk to each other and be understood if we're all defining malnutrition differently? So now we have a definition. There's a standardized ideological-based definition of diagnostic nomenclature that accounts for what we know about the inflammatory response. That's probably one of the biggest changes, is as we've learned more about inflammation, we have changed what we characterize as malnutrition. And of course, because we have all of this data now and we have computers, there's been a lot more literature out there. I've been in this field for quite a long time at this point, and at the beginning, we really didn't have a lot of good studies. We didn't really know. But now, because data collection has gotten so much easier, there's just been a boom of nutrition studies that really support what we need to do for our patients as far as nutrition and even in wound healing specifically. So there's a lot more data out there. So what are these characteristics? Well, we can now diagnose malnutrition when 2 of the following 6 are present. So let's just read through these 6 quickly. Insufficient energy intake. Someone is simply not taking in enough energy to meet their needs. And in wound healing, you need more energy than you would normally. And we'll talk about that specifically in a moment. Patients who have weight loss. Patients who have lost their muscle mass. Patients who have lost subcutaneous fat. Localized or generalized fluid accumulation. And sometimes this might mask the weight loss because that fluid has weight to it. And when you put someone on a scale, the number might be the same, but maybe they're really losing some muscle underneath because that fluid is masking their weight loss. And then one you might not be so familiar with, which is diminished functional strength, functional status, functional strength, and how we measure that is by hand grip. So I just want to talk about 2 of these a little bit more in depth. Just wanted to give you a taste of what we now feel are the signs of malnutrition. Here, but before we do that, I want to mention one more thing. What's not on this list? What you don't see on this list is prealbumin or albumin. And you're probably thinking, that's kind of weird. Well, we don't use that anymore in the nutrition field because we've learned that when a person has an inflammatory process going on, which most of our patients with wounds do, they have some sort of stress on their body that is changing their hormonal milieu as far as the stress hormones, their inflammatory status, that alters the entire class of hepatic proteins. Hepatic proteins being those proteins that are manufactured by the liver, including your prealbumin and your albumins. And we know that that's not really indicative of their nutritional status. What it's more indicative of is their morbidity and their mortality and how sick they are. So we don't really use that as a way to show somebody's nutritional status anymore. So that's one thing that you might want to change. Not to say that prealbumin and albumin are useless; they're certainly not. But we don't use them as a way to diagnose malnutrition anymore. So the two that I kind of wanted to just mention a little more is this loss of lean mass, because this is very important. And there's on your slide now all different places on the body, the temples, the clavicles, the quadriceps. There's all different places on the body where you can learn to do what we call a nutrition-focused physical exam, where you look at these particular points on the body and you can tell if they are wasting. And so unless you're looking and you are aware that there are telltale signs of malnutrition along the way, you might overlook it. If you're not looking, you're not going to find it. And here are some of the places where you can definitely see this loss of lean body mass. And when a patient is losing lean body mass, that is quite detrimental to their ability to heal a wound. And we'll talk about that again as we get into the nutrition portion of this. And then the last one I wanted to mention here was this whole business of hand grip strength. A hand grip meter, here I think I have a picture of one on the next slide for you. It looks like this. You just give this a little squeeze. The little window here shows what your hand grip strength is, and then you put it into a formula and you can tell somebody's functional status. This is a validated proxy for lean body mass. Okay, if somebody has no hand grip strength, that can show that they are wasting. So for a little gadget on Amazon for $29.99, you can get a little clinical test in to see if somebody is losing their lean body mass. There are other little tests you can do, a little walk test, a sit to rise test, a little stair climbing, peak flow test. If you have a patient with COPD or asthma, you might already be doing peak flow tests. But there are all these little clinical tests now that we're incorporating to show if a patient has malnutrition. So that's just a little taste of what's happening in the nutrition world. But again, the real take-home point that I want you to walk away with from this little section of my presentation is that we do have a definition of malnutrition that everybody is using across the boards these days. We have to because of the electronic health records. Everyone's defining it the same way. But even though we have that, I don't see that a lot of people are looking for it. So you have to be on the lookout for malnutrition because it happens kind of insidiously, slowly over time. It's not, Monday they're fine, Tuesday they're malnourished. This is something that is happening that you have to be aware of, especially if their wound is chronic or not healing, or you're not getting the results that you might think you are, that you should be. You might be thinking to yourself, heck, we have great wound care here. Why is this patient not healing? It's been weeks after week, and there's no progress being made. It could be because their nutritional status is stymieing the very good wound care that you're doing on the outside of the body. If they don't have the nutritional wherewithal on the inside of the body to build that new tissue, you might not get the results that you want, which is why nutrition is so important. So what are these ingredients in my little recipe I've concocted here for us today? What do you need to do? Well, let's start out with calories. Energy, calories, basically talking about the same thing. We have to fuel that wound healing process. Give it gas. It's like your car. You have to give gas to your car or else you're not going to go anywhere. You have to provide enough energy or calories or you're not going to get anywhere in your wound healing. And when patients don't take in enough calories, how does that manifest itself? Well, as this weight loss. Now, you might see, I see a lot of patients who they bounce around. They've lost 2 pounds this week, then they've gained a pound, then they lost 3 pounds. So you've got to look at this over time. If they're on this downward trajectory, they're probably not taking in enough calories or their body is using more calories than it normally would. I've worked a lot of nursing homes and long-term care, and sometimes I would go into these facilities and they'd be just waiting for me to walk in the door. And they'd say, Nancy, oh, Nancy's here, Nancy's here. And they'd give me this big list of all the patients who were losing weight. And sometimes it was many times it was a pretty hefty list. It seemed like everybody was losing weight. And I treated all of those patients basically the same. Now we know it's gotten a little more sophisticated. We know that there are different mechanisms of weight loss and that these patients are losing weight by different means. And we have different treatments available. But with our wound care patients, what's typically happening is that they are losing weight due to a stress response. The wound is putting stress upon their body, and that is changing the way their body handles nutrition. And the consequence of this stress response, this increase in catecholamines, the increase in cortisol levels, what that does is the problem is not so much that they're losing weight, it's that they're losing lean body mass. Okay, that lean body mass compartment of the body is highly protected. You should not, in a normal circumstance, be losing lean body mass. When I say lean body mass, what I'm talking about is the metabolically active tissue of your body. That's all your muscle, including your heart muscle, those intercostal muscles that run between the lungs to help you breathe, your skin, all your vital organs. That's all part of your lean body mass. The fat and the extra is the adipose. That's metabolically inactive. So the lean body mass is typically highly protected, and you should not be losing that. The problem with our patients with wounds is that often their weight loss is loss of lean tissue. And we have to find some ways to correct that. The term for that is catabolism. The body is actually breaking down or catabolizing its own lean tissues, typically because your calorie needs are not met. When you're not taking in enough calories, it doesn't negate the body's need for them. It's still going to need calories. So where is it going to get it from? Well, I've got a couple of ways as a dietitian. I can put it in somebody's mouth. They can eat it. I can put it in a tube. That about exhausts my abilities to get more calories into a patient. If they still need even more than that, what the body is after is glucose, and where it can get more glucose from is by breaking down muscle. So this is the process that's happening in a lot of these patients. It's not, they've just lost 2 pounds. No, it's that they've lost 2 pounds of vital lean tissues. So what does this have to do with wound healing? Well, we know from the research that's out there that what happens is that when a person is not taking in enough calories, there becomes a competition for the nutrients. The body's very smart, and it has to say to itself, I've got a limited supply of nutrition here. What shall I do with it? Should I put it towards the wound and build new tissue to heal that wound? Or should I put it towards the heart, the lungs, the intercostal muscles, and keep this patient alive? Obviously, if your heart becomes totally wasted or you can't breathe because you can't function, you can't move the muscles that are going to make your lungs function, you're not going to do very well. And what the research shows is that when a patient has lost less than 10% of their lean tissues, wound healing has the priority. Everything will be okay. We're going to do well. But if you don't check that, if you don't attenuate that loss, when it gets to greater than 10%, at that point is where the competition really heats up. And the stimulus to restore that lost lean body mass is going to start competing with the wound. And the body is going to have to say, okay, well, maybe we'll give a little towards wound healing, but we're going to give a lot towards keeping this patient alive and give the vital organs. And so this is where you might see your wound healing start slowing down because they're not getting enough calories to prevent them from losing weight. And when it gets to, if you allow this to continue and it gets to above 20%, at that point, the correction of the lean body mass takes precedence. And at that point, nothing is put towards the wound healing. So this is why calories are very, very important, because if your patient is not taking in enough calories, there's going to be this competition for the nutrition that is available. So what are you going to do? How are we going to increase calories? Remember, I said I wanted to give you some ideas of what you can do. Well, this is just kind of a mixed bag here, offering favorite and culturally appropriate foods, things that people want to eat. Maybe this is the time that you liberalize the diet order. Do they really need that totally restrictive diet if they're not eating well and losing weight? Having people socialize. And again, I think that people listening today might be in home care or acute care or long-term care. There's all different settings. So maybe what's appropriate in your setting. Socializing at mealtime. In long-term care, a lot of times patients eat in their rooms and no one's really supervising them and it's not that enjoyable. Getting people to a dining room, maybe that can help. Smaller meals throughout the day, keeping the food coming. Sometimes a big plate overwhelms people and they don't want to eat it. Proper positioning. I'm sure we have all been in that hospital room where the patient is like basically lying in bed with a bed table over his chest with a urinal on it, with a whole bunch of other deck of cards and a hairbrush and a this and a that, and it's not very conducive to eating. So proper positioning, people have to be sitting upright, able to get to the fork, able to handle the drinks properly. You've got to make sure they're positioned. Maybe they need assistance. A lot of patients with dementia and Alzheimer's type diseases, they can benefit from cueing, giving them signals, verbal signals, using hand over hand to get them started, eating, showing them the motion that they can repeat. Mirroring, you eat, they eat. So there's all different kind of techniques that you can use. But again, I think that sometimes we're doing some of these things, but we think, oh, these are basic and they don't get in the chart. If you're doing any of these things, these are interventions and you should make sure to document them so that you get credit for doing these things. Again, when we look at the charts in retrospect, if these things aren't in the chart, it can look like you're doing nothing. Recipe modification, I can make a bowl of soup that's 300 calories or 100 calories. You can get the most, by changing your recipes. I'm sure a lot of us have done this the opposite way. How many of us have tried those recipes where we make brownies with applesauce instead of, the higher fat ingredients, trying to make a low-calorie brownie? Well, you can do the opposite for patients who need more calories. We can modify the recipes so that they're higher calorie. And then, if you still can't get them to eat and you need to fill some gaps in their nutrition, there's plenty of pre-made oral nutrition supplements available. And a lot of times people tell me, oh, they don't want to drink that, Nancy, they don't want to drink that. Well, there's plenty of forms out there. Besides a liquid or a shake type product, there's puddings, there's bars, there's cookies, ice creams. There's all different forms out there, a whole industry catering to these patients. You've just got to try different products. And then, of course, there's appetite stimulants. If the source of somebody not eating is that they really don't have an appetite, there are pharmaceutical agents that you can try. One of the cautions with that is that, again, these things don't work overnight. You can't order it on Monday and think on Tuesday, oh, they're going to start eating everything in sight. It just doesn't work that way. You need it probably, according to most of the manufacturers of these products, 2 weeks to let these reach therapeutic blood levels. So again, if you're ordering these, if you're in acute care, you have to make sure that then that continues to where they go post-acute. Acute care has to have some communication to make sure that these nutrition orders are continued in the post-acute world. And a lot of times I see that is not happening. And that's detrimental because sometimes I see you're on the right track, But if it doesn't get continued once they change to a different point in the healthcare continuum, of course, then the plan of care just, goes kaput, and that's not good. Okay, so we know we need calories. Along with calories, part of the calories, one of the macronutrients that make up calories is protein. And I'm sure if you're in wound healing at all, you understand that you've heard protein, protein, protein. Why is protein so important? Because it's the only nutrient that contains nitrogen. And you need nitrogen at every step of the healing process. You need nitrogen. It helps synthesize the enzymes. You need it for collagen synthesis. It is very important that patients get enough protein because the other two macronutrients, which are, of course, carbohydrates and fat, do not contain nitrogen. So unless your patient is getting enough protein every day, they're going to be lacking nitrogen, and they'll be in, what's called a negative nitrogen balance or a nitrogen imbalance. How much protein will they need? Well, here's a little chart for you. Let me orient you here. The first line is the RDA. The RDA, as we know it, is 0.8 grams of protein for every kilogram of a patient's body weight. So I kind of worked this out for you so you can see it in some real numbers because, that's not very useful, at least not to me. What does 0.8 mean? If you have a 140-pound patient, that would equate to 51 grams of protein. And if you, again, still even grams isn't that useful to me. If you convert that to ounces, that would be 7 ounces. Okay, and that means 7 ounces of a meat, fish, chicken, soy, if they're a vegetarian, eggs, milk, where you're getting your high protein from. When we look at the literature, we know that that's probably not adequate for most patients who are elderly, who have chronic diseases, who have a stress response. We know that that is more like 1.2 to 1.5 grams of protein per kilogram of body weight. So for a 140-pound patient, now we're looking not at 7 ounces, but more like 11 to 14 ounces. And again, depending on your environment, if you work in acute care, maybe you're critically ill, your trauma patients, some of your burn patients that have wounds, they probably need even more, maybe 14 to 18 ounces. Now, that's a lot. Okay, let's just stop and think about this. Of course, I'm in Las Vegas, the land of, the 36-ounce T-bone, but most places are not going to be routinely serving this, nor are patients going to be consuming this amount. So we're going to need to have a plan if we're going to meet these elevated needs. And again, if we don't meet the patient's needs, they can be catabolic. Wound healing, by its very definition, build new tissue, is anabolic. That's an anabolic process. It will be virtually impossible for your patient to be both catabolic and anabolic at once. The body is not going to be breaking down and building up in a wound selectively. That just doesn't happen. So we have to use our nutritional tools to get somebody out of this catabolic state and into a more anabolic condition so that they can build the new tissue for wounds. Now, before we move on, I just wanted to give you one caution here, actually two cautions here. Obviously, if your patient has renal impairment, if they have a GFR that is low, maybe bordering on the need for dialysis, or they want to maintain kidney function, you make sure that you evaluate that and weigh that against the need for increased protein. Also, if we're going to increase protein, we have to make sure that that patient has enough fluids. So these are general rules. Well, all of what I'm talking about are general rules. General rules are for the many. You are treating the one. So use your clinical judgment for your one. Okay? Usually after these things, people are quoting me on the internet. I want to make sure that you understand that these are general rules, and you all have good clinical judgment, I'm sure, and you need to adjust these general rules for your particular patient. Okay, here's a interesting study that I wanted to share with you because this is something that you can easily do that doesn't cost any money, that will be very easy, that can help your patient quite a bit. You can see on the left side of your screen, we're talking about breakfast, lunch, and dinner being 30 grams of protein each in even distribution. And the dotted lines, that shaded area at the top, is the maximum level of protein synthesis. When someone is eating consistently through the day, their protein is divided, you can see that morning, noon, and night, they're reaching that maximum level of protein synthesis. Now, the problem is that a lot of my patients do not eat that way. For breakfast, I've got a lot of little ladies who want to have a piece of toast and a cup of tea for breakfast, or they have a half a bagel and a cup of coffee. That's not a lot of protein. They're not going to be reaching that maximum protein synthesis level by having that small breakfast. So you can see in the darker blue area on the right side of your screen, the skewed protein distribution, we're still talking about 90 grams of protein. This isn't any more protein. It's just divided differently. So instead of having the tea and toast for breakfast and maybe the half a tuna sandwich for lunch and then the bulk of the protein at the dinner meal, if we could adjust this a little bit, we can help them synthesize protein more consistently through the day. And that would help our patients with wounds. So let's get back to the real world here. If I've got a patient who for their whole 80 years has only had tea and toast for breakfast, I'm not going to suddenly be able to convince them to have this 4-egg omelet for breakfast. So we've got to have some other ways to do this, which we'll talk about. Okay, so we can give your patients food. And again, high protein foods, eat eggs, beef, chicken. Vegetarians can still get adequate protein from their nuts, their legumes, soy products. We've got protein shakes. I'm sure many of you make protein shakes for breakfast yourself. But then one of the ways that we can also do this is by giving them some sort of a modular protein. We can give that, sometimes you can add that to food, you can give it with their meal or with medications. And here I'm talking about either your liquid or your powdered proteins. I'm sure if you've been to, the big box stores, you've seen whole aisles that have these jugs of protein. It's obviously very popular these days. And like I said, I'm sure some of you are making protein shakes yourself. You can get this typically in a liquid or in a powder that comes from all different protein sources: whey, collagen, soy, casein. For wounds, I like a collagen protein because collagen has more proline in it than the other sources. And typically the Western diet is low in proline, and wound healing has a very high need for proline. So by a collagen supplement, we have more of a proline donator. But again, to me, probably on this whole list of considerations for a protein supplement, the number one is palatability. If someone's not going to consume it, it's not going to do any good. And there are many, many flavors available. I typically like a little 1 ounce, shooter type of a liquid protein. I can get 15 grams, depending on the product, about 15 grams of protein into somebody in a very small quantity. So if my patient wants to just have tea and toast for breakfast, they can have tea, toast, and their little 1 ounce of liquid protein, and the problem is solved. But there are plenty of products out there, and the best advice I can give you is just to try different products and different flavors until you find one that particular patient likes. There's everything, from watermelon to cherry to tart lemon. I'm sure you can find something that someone would be able to consume, but you're only going to do that by trial and error. And fortunately, most of these companies will give you a lot of free samples, so you can try and find something that everybody likes. But your goal would be to try to even out their protein distribution through the day. Okay, so now what happens when you consume a protein? Well, that brings us to little ingredient number 3 on my little recipe for wound healing here. We've got calories, we've got protein, and now we've got amino acids. When you consume a protein, your digestive system breaks it down into, the individual amino acids. And then your body takes those amino acids and recombines them to make new amino acids. So your body is always breaking down the protein. That, of course, is the process of digestion, and then building new protein. So let me show you a list of the amino acids here. Okay, our first column, those first 9, are the indispensable amino acids. This means that you have to get these 9 from an exogenous source. You have to get these from food. Okay, no other way to get these. You have to get these from food. Your body will disassemble these and reassemble them into the other 2 columns. That middle column are the dispensable amino acids. Your body is making those all day. The last column are the conditionally indispensable amino acids. Your body is making these as well. But why these are in a special category is that there's been some research out there that shows while your body can manufacture these, it probably can't keep up with the demand for some of these in times of stress and disease and other medical problems. Yes, your body's making its own supply of the conditionally indispensable amino acids, but can it make enough? And in wound healing, the answer is no, it probably cannot make enough to keep up with the demand that you need for wound healing of the 2 that I have here in light blue, arginine and glutamine. I also have leucine in light blue for a different reason, and we'll go over that now. So what's happened here is that if we realize, oh, well, if the body cannot make enough arginine and glutamine from the other proteins that the person is consuming, why don't we supplement these? So amino acid supplementation is something that's been done now for several years and has worked well to fill in, again, that gap in what your patient needs and what that patient is able to produce. So why is arginine important? Well, most amino acids are 16% nitrogen. Arginine is a unique one because it is 32% nitrogen. So it is considered a very nitrogen-rich amino acid. And exactly what we said, your patient needs to be in a nitrogen balance that's positive in order to heal a wound. Every day we're building a little protein, we're breaking down a little protein, but generally we're in protein balance. Our patients, unfortunately, are not in a nitrogen balance. A lot of them are in a negative nitrogen balance, meaning that they're losing nitrogen. We have to try to attenuate that loss and try to manipulate them using nutrition to get them back into a positive nitrogen balance. And one of the ways we can do that is with arginine, to make sure that the lack of arginine does not become a rate-limiting factor. If you run out of arginine, then the rest of the reactions can't take place. And one of the key reactions that you need arginine for is to synthesize nitric oxide. Nitric oxide is extremely key to wound healing. It activates the macrophages. It improves the vasodilation or the blood flow to that wound bed. It helps with the collagen formation. It helps keep the infection rates low in the wound. It's bactericidal. So there's a lot of things that arginine does. It's also the precursor to proline. Proline becomes hydroxylated to hydroxyproline, and hydroxyproline then becomes collagen. So if you run out of arginine, all of these key reactions that you need to happen for wound healing will come to a halt. So we've got to make sure. So you think, well, my patient, well, maybe they're not running out of arginine. Well, let's look at it this way. If they're not eating an adequate amount of calories, and they're not eating an adequate amount of protein, they're not reaching those elevated levels that we discussed, where do you think the arginine is coming from? They're probably running out of arginine. So unless we supplement this, it could, in fact, become the rate-limiting factor in their wound healing process. Arginine kind of goes hand in hand with glutamine. Glutamine is the most abundant amino acid in the body. We have more glutamine than everything. But we're making a lot of glutamine every day, but we're burning through a lot of glutamine every day. I'm sure if you've ever worked in critical care or trauma, you know that glutamine is something that has been around for years. We definitely know we need more of it in trauma, in sepsis. It's been definitely well researched in those areas. And we have taken a lot of that information and translated it to our patients with wounds. We know that, again, you need glutamine for the stimulation of collagen synthesis. We know that it regulates that nitrogen metabolism. So if your patient is catabolic, one of the ways that we can help them attenuate that catabolic state is by making sure that they have enough of these key amino acids. Glutamine helps regulate that nitrogen metabolism. It supports the immunity. It supports gut integrity. So glutamine is very important as well. Now, you're probably thinking to yourself, well, why didn't we supplement this, right from the get-go? The problem with supplementing some of these amino acids was that we really didn't have a way to get an efficacious amount into the patient. Arginine kind of has a fishy base flavor, and to get an adequate amount into a patient, I would have had to given them a handful of pills. It would have been like, oh, Mrs. Smith, here's your 10 medications and here's your 25 Arginine pills. It just wasn't practical. Now we have ways where we can give them a supplement that is, they'll consume without any problem, that's easier to handle to get them the right amounts. Now, leucine was the other one that I had highlighted. Why did I have leucine highlighted? Well, leucine is one of the branched chain amino acids, and what we know is that it stimulates something called mTOR. mTOR stands for mammalian target of rapamycin. Now, that's a mouthful right there, but basically what it really is, simply put, is a protein kinase that acts as a cell signal to turn on protein synthesis. So basically, you can think of it as your traffic light. When you have enough leucine, that's one of the traffic lights, one of the signals that make the traffic light green and tells the body to stimulate muscle protein synthesis. So if you run out of leucine, again, you're short on that protein kinase. But more than leucine, what I'm interested in is that 5% of leucine is converted to something called hydroxy-methylbutyrate, or HMB. Now, HMB is a very interesting little derivative of the amino acid leucine here. If you look on Google today after this and you look up HMB, the first several pages will be about exercise science, particularly people who are lifting weights and want to have less muscle soreness and want to lift more reps and heavier weights. A lot of this comes out of the exercise science because they're trying to protect their muscles from the stress of working out, because they don't want to have 3 days of recovery. They want to work out consistently. And we've taken a lot of that exercise science, and where it first went, it's pretty interesting to see the history here, was to the HIV and the AIDS crisis. They were able to apply some of that science when the AIDS crisis first hit. A lot of this AIDS wasting occurred with the new drugs. That doesn't happen so much, but it went into that world. And from that world, it went into a lot of other clinical worlds. And now we know that for wound healing, we also want to help protect the muscle from breaking down. And you can use HMB to do that. Again, we don't want these patients in this negative nitrogen balance, in this catabolic state. How can you build new tissue to heal a wound if your patient's in that state? So we, again, have the nutritional tools now to manipulate this a little bit. And so it's really, as a dietitian, it's very exciting because I didn't have these kind of tools always available to me where I can actually, again, really manipulate somebody's nutritional status and help them heal their wounds better. So what HMB does, if you're interested in the little technicalities here, what it does is it's a precursor for the manufacture of cholesterol, not the blood cholesterol we're trying to get down, but the cholesterol that's in the muscle membrane. So it slows the muscle tissue breakdown. It helps keep that muscle membrane intact and not break down. And it also helps support the immune system. So it really has some anabolic support. It helps reduce that inflammatory process, decreases the muscle breakdown, helps put on the lean muscle mass, and protects the muscle from stress-related damage. Quite a little package there. There's been some great studies out there that are pretty exciting, again, in this area, because one of them that I wanted to tell you about, it's done by a guy named Nicholas Dutz, okay, and it's a well-read study. If you're interested, you can easily look up his name. It's Deutz and find the study on HMB. He basically put people on bed rest and gave half of the patients HMB and half of the patients a placebo, and measured what happened to their muscles. And on bed rest, the patients who got the placebo, they lost a lot of muscle mass. But the patients who got the HMB, their muscle was protected, just as we suspected, and they really didn't lose very much. After the period of bed rest, he put them on a period of strength and recovery training. And the patients who got the HMB not only got back to their baseline, they exceeded it, while the other group never really did get back to baseline. So it really is very exciting that we can use some of these nutritional components to really alter the way the body handles this inflammation and this nitrogen balance. It's a very exciting time for, certainly people in this field. Here's another study I wanted to show you. Again, just how we are looking at combining some of these things. This is a study that was done in mice. They had tumors that made them cachectic. The green bars are protein synthesis. Blue bars are protein breakdown. So there's 5 different situations here. The first one, of course, is the control. You can see protein synthesis and breakdown are about the same. Next one is the cachectic situation, which, of course, that is the hallmark of cachexia. The breakdown is tremendous, and the synthesis is rather low. That's a tiny little green bar. The next one was when they were supplemented with glutamine and arginine. Brought the breakdown a little bit, made the synthesis go up a little bit. HMB actually did more, exactly what I showed you and what Dr. Deutz was able to show in his study. The breakdown was really cut down, at least in half. And the last one in the blue box is the combination of HMB, glutamine, and arginine. And when the 3 of them are combined, you can see that it almost mimics the control. So these are some of the ways we're looking at trying, again, to manipulate somebody's way that they utilize the nutrition that we're giving them. So again, exciting to see what's happening out there. Okay, the next ingredient here are your vitamins and your minerals. People always ask me, should we give supplements? Well, you generally can meet your needs with a healthy diet. The problem, of course, is that many of our patients are not eating an optimal diet every single day, especially if they've got heavily draining wounds. I think it is reasonable to give a multivitamin every day. I'm sure plenty of you take multivitamins every day. NPUAP says offer vitamin and mineral supplements when dietary intake is poor or deficiencies are confirmed or suspected. So I think there's really not too much problem with offering a multivitamin. It gets a little bit more complicated when we want to start giving them bigger doses of specific vitamins, such as vitamin C. Yes, we know we need vitamin C. It is the cofactor for the hydroxylation of proline and lysine to hydroxyproline and hydroxylysine. So if you don't have vitamin C, this hydroxylation won't take place, and that certainly will affect your collagen synthesis ability. You need it for tensile strength, that newly built collagen. Sometimes our patients break down in the same area that, it's healed one week and then, oh, darn it, next week it's broken down again. That's because that newly built collagen didn't have the tensile strength, that ability to stretch and not break. Skin is elastic. We want that newly built collagen to be able to bend and stretch and not tear. You need vitamin C for that. The body doesn't store vitamin C. We know that. It's water soluble, so you need it every day. Is there a lot of research I can point you to? No, because, again, it's a generic, not costly product. I personally think it's reasonable to give people vitamin C. I've been fighting a cold myself. I've been taking all sorts of vitamin C. I don't think it's going to harm anybody. Zinc, on the other hand, is not water soluble. It's stored in the body. You need this for all the enzymatic reactions for wound healing. If someone's deficient, they might have a low rate of epithelialization. So the question again becomes, do we give zinc? Do we not give zinc? How do we figure this out? Again, there's not a lot of research out there. People are not studying zinc. What we do know is if somebody is zinc deficient, correcting that deficiency certainly is a good thing. But do people need more above and beyond the deficiency? Probably not. You can get zinc overload above 40 milligrams a day. And if you have zinc overload, that in turn is going to cause other problems that will interfere with wound healing. Specifically, you'll cause a copper deficiency. And if you have a copper deficiency, that is going to be detrimental to wound healing. So you don't want to cause a copper deficiency. So these days, it's hard to tell if somebody is zinc deficient. You don't know if zinc's deficient. But if someone has chronic diarrhea or they're using corticosteroids or maybe they're very malnourished, yes, maybe they are zinc deficient. So the trend today is to supplement zinc for a short amount of time and measure the response. So you can order zinc maybe for 2 weeks for somebody and see what happens. If their wound starts getting better and they're generally getting better as a patient, then maybe they were zinc deficient and you've corrected it. If you see no effect after like a month, well, maybe they were not zinc deficient, and at that point you should discontinue it. I had this one patient with the same wound for like 8 months, and when I was reading the chart, I realized that they had been on zinc for 2 years straight. That's definitely a no-no. To keep someone on zinc for 2 years. By that point, I'm sure that they had a copper deficiency. So you want to monitor the therapeutic response to any of these supplementation. Because again, as we said, copper is a good cofactor for this connective tissue proliferation. It enhances scar strength. You don't want to have a copper deficiency in turn. Okay, our next ingredient here is fluids. And I think sometimes fluids doesn't get its due because we figure, oh, well, everyone's drinking a little every day. But for our wound patients, it is particularly important for 2 reasons. A lot of patients are maybe on air fluidized mattresses. They might be on these special beds to help them heal. And if it's on an air fluidized mattress, that is very dehydrating. So you want to make sure that they're getting adequate fluids. The other reason is that sometimes these wounds have a lot of exudate. They're heavily draining. You might need to replace that. Also, if your patient has dehydration or fevers or sweating, all of those things, they might need more fluids. Again, the general rule of thumb that I like to use is provide 1 milliliter of fluid for every calorie that I'm providing. The other way to think about it is 30 milliliters per kilogram of body weight. But you want to make sure that your patient is getting an adequate amount of fluids, again, especially if they're on a special bed or their wound is heavily draining. And so you have to make sure that fluids are also included in this little recipe here that we're building. So I wanted to leave some time for questions, so let's just review where we've been here so far. So the first step is to evaluate for malnutrition. You've got to be looking for it. You've got to know the current diagnostic criteria for malnutrition. You've got to really concentrate on looking at their whole body, finding that loss of lean body mass at all those different body points, doing a little bit of a nutrition-focused physical exam. And then we've got to make sure that they have the right amount of nutrition. And that means calories, protein, amino acids, vitamins and minerals, and their fluids. So getting back to what my editor wanted, one article that talks about the most important thing, is one of these more important than the other? No, I don't know if one's more important. It takes all of these things together to make someone have a good nutritional status that's going to have all the energy, all the fuel, all the gas that's going to fuel this wound healing process, and then all the cofactors that are needed for all of these reactions that need to take place in the wound healing cascade. You can't run out of vitamin C. You can't run out of arginine. You can't run out of nitrogen. They all contribute something in this recipe. And then, of course, you have to monitor closely and refer to a registered dietitian if necessary. You can always get some help here from your registered dietitian who can deal, again, not with the general rules, but with what that specific patient needs and will eat. We must all work together to communicate the nutrition message because, as they say, there is no love sincerer than the love of food. So let's take some questions now. I'll turn it back to Demuriel.
Well, thank you so much, everyone, for attending today's webinar. This concludes the continuing education portion of this webinar course. We have included the references here in the presentation, and they're also available to view in the handout. So we'd like to thank Dr. Collins for a wonderful presentation. And at this time, if you guys have any questions, please feel free to enter them into the question box now, and I will go ahead and read them off for you, Nancy.
Okay.
One question that we had from several people, I think, is my patient is very obese in the area of 350 pounds. How do I know how many calories he needs?
Okay. Yes, a lot of people today are very obese. Now, so there's a couple of ways to determine how many calories someone would need. Of course, the ultimate way would be something called indirect calorimetry, where we're actually measuring with a device, which sometimes is not available, which is why we don't do it all the time, how many calories someone needs. What the problem with obesity is that you only need to feed really the lean portion. So we use predictive equations. There's many different predictive equations out there that kind of work to predict how many calories does somebody need. And some of these equations are better for obese patients than others. So these are formulas you might have heard of with names such as the Harris-Benedict formula or the Penn State formula. There's different equations for different populations. So I would recommend that there's a good article out there on all of these predictive equations, depending on what that patient's problems are and their other medical conditions are. You can use an equation that will deduct some of the adipose tissue from the numbers. Because if you just use their straight weight, obviously you're going to come up with some ridiculous number like, 6,000 calories a day. That obviously is not what's needed. So you have to be able to look at their body composition and deduct some of the portion of that adipose, which is, again, metabolically inactive, and you're not going to worry about the calories needed for that portion of the body.
Thanks. So another question in regards to the estimating the protein, they wanted to know, are those values per meal or per day?
Those values are per day. So you figure about 1.2 to 1.5 grams of kilogram of body weight per day.
Great. Okay, here's another question. How long should a patient take amino acids?
Okay, well, amino acids, there's two different answers here. If you look at some of the studies, the longest study that I know of looked at 24 weeks. Certainly there was no problem with 24 weeks. On the other hand, I have met people, at the gym and people who exercise a lot who have been taking it literally for years without any problem. So I think somewhere between 24 weeks and forever is probably the right answer. I don't think we have a specific answer there. As for our patients, we have to be practical because, of course, that's, cost is always a concern and patients get tired of things. So when we're dealing with a wound patient, I would probably try to encourage them to take the amino acids until wound closure. Okay. And I think that would probably be the most practical bit of advice there. At least, on the other hand, let me just add one more thing here that I just thought of. On the other hand, the minimum would be 2 weeks. Again, this isn't a one-time deal. You're not going to take it on Monday and, oh, look, my wound is healing on Tuesday. You've got to take it for about 2 weeks, again, to replete those amino acid pools and get things back on track. So a minimum of 2 weeks, and I would try to encourage them until wound closure.
Great. Okay, here's another question. We have a couple of the same question also for this one. How do you document that a patient is malnourished without diagnosing, so to speak?
Okay, well, malnutrition I think I kind of understand the underlying bit of this question. I think this is getting to the point of the historical position that dietitians are not a discipline that diagnoses patients. Obviously, medical doctors, nurse practitioners, licensed independent practitioners that do the diagnosing. But the times have changed. Dietitians certainly are qualified to give a nutrition diagnosis. I mean, and when you think about it, if the dietitians are not doing a nutrition diagnosis, who is? And I think that this is some of the problem why malnutrition never gets in any of these charts. So yes, the dietitian certainly, the nurses, you can all make a nutrition diagnosis. And then what happens is that then the licensed independent practitioner, the LIP, could be able to refer to that nutrition diagnosis, and if in agreement, adds it to the official diagnosis list. And that is the list that then becomes coded and is used for reimbursement and those sorts of things. But there's no problem with a dietitian making a nutrition diagnosis. If we're not looking after nutrition, who is? Then it goes by the wayside. Did that answer the question? Read me the question again, Dee.
So there was another question. It was,
okay.
Can the nurse diagnose, basically?
Can
malnutrition?
I think that if you're documenting it properly, you can make a nutrition diagnosis based on, again, there are those 6 criteria, but in order for it not to be thrown back by your coders and your billers and your third-party payers, when they go through the chart, you need to have those key words in there so that the system picks it up. So if you're saying, yes, patient has a diagnosis of malnutrition, what is that based on? Is it based on the fact that they've had inadequate caloric intake for so many days, or that they've lost such and such a percentage of their usual body weight over the time specified time frame over the last 30 days? You need to be very specific in your documentation, stating the weight loss as a percentage over a period of time, stating caloric intake, that they're eating 80% of their estimated needs, or whatever that percent is. And that's the best way that you won't get denials down the road. So yes, as long as you have proper documentation, it has to get in the chart somehow. And again, it depends on the environment. And obviously, hospitals have dietitians there every day. Nursing homes, maybe not so much. Home care, maybe not so much. So we do have to rely on the nurses more to be looking for these nutritional problems in those type of care settings where a dietitian may not always be present. You just can't let it go to the wayside. Somebody's got to pick up the slack in those environments.
Great. So we have time for just a few more questions.
Sure.
This next question, I'm going to read exactly what she said. I work in an acute care setting. I realize that some of the elderly or more confused patients who may have these non-healing wounds just don't get fed because they're either refusing or the nurse doesn't have time to feed them. What is the recommendation as far as helping these patients achieve better intake?
Well, that is, to me, with my expert witness hat on, a very risky question there, because you can't just say, oh, we don't have time to feed the patients and their wound is not healing. If that ever came to any sort of a chart review for the legal situations there, that would be obviously very detrimental and hard to defend, saying, oh, well, we're just too busy. The practical things that you can do, of course, is trying to make sure that patient has foods that they like to eat. If they have visitors every day, providing them with training and documenting that you train them on safe feeding techniques. The food, the problem with nutrition is it's 21 times a week, 7 days a week, 3 meals a day. As soon as you get one meal done, it's like almost time for the next meal. And I understand, believe me, I have been on that side. I understand that it's, sometimes a battle over and over and over every day to try to get the nutrition in. But, you're just going to have to make that effort. There's just no way around it.
So what about those that they just want fast food all the time?
Well, here again, we have the question of between the patient rights of what they want and what's there actually is going to be good for their body. I guess the only way to tackle that one is with education and trying to tell them that maybe fast food is not the best choice. I mean, and there's all sorts of nutrition counseling techniques where you try to move someone from their point, a little bit at a time. Maybe if they're having fast food 5 times a week, you could get them to agree, well, maybe next week we can try for only 3 times a week and see if you can move them a little bit at a time. But make sure that all of this education and gets into the chart because, again, it all has to be documented should there ever be a question later on.
Great. Okay, one more question, and that will be the end of the webinar.
Okay.
What should we do if my patient is expected to lose weight, like towards the end of life?
Okay, well, certainly we cannot prevent every single solitary patient from losing weight. And again, it all goes down to the documentation. Yes, and again, I've had a lot of cases like this, again, with various legal situations where a patient has end-stage Alzheimer's. And yes, losing weight is a hallmark of the end stage of that disease. But a lot of times the care plan doesn't match that. They're still writing care plans that say patient will eat 75% of their meals, patient will maintain current weight. Yes, you have to kind of get over the fear of documenting that, yes, weight loss is expected, that people are at end of life. I think in this country as a whole, we don't like to kind of deal with this whole end of life issue, except in, a hospice environment maybe. But yes, there are certain diseases where patients are going to lose weight, and that is acceptable, but then you've got to get that in the chart and make a care plan that's appropriate for that. And maybe some of these interventions are not appropriate. You have to set your goals realistically. Not everyone's in a curative stage. Some people are in a rehab or a maintenance stage. Some people are in a comfort care stage. But the whole chart kind of has to jive together. And I think that that's probably the biggest problem that I see is that when we look at, again, when you look at these charts retrospectively, that, there is a saying, hindsight is 20/20, because it's true. I look at these charts and I think, I wonder why these disciplines weren't talking to each other. Why is one having one goal and another discipline's having an end of life goal? You've all got to be on the same team, and the documentation all has to be logical and jive and make sense together. So yes, patients sometimes lose weight, and that is acceptable. And that is, again, the hallmark of various diseases. And it's okay to document that.
Great. Well, thank you so much, Nancy, for answering questions and doing a really great presentation for everyone today. As a final reminder, everyone, you will receive an email within the 24 hours with instructions on how to obtain your certificate of completion. Thank you again for attending, and everyone have a great day.